Okay. Okay, so hi everyone. I'm Bethany. I'm one of the Ahmed residents, for those who don't know me. Um, I'm going to be presenting an article that I looked at called Evaluating the Impact of the Sleep Health Education and Personalized Smartphone Application on Sleep Productivity and Healthcare Utilization Among Employees. And it's the results of a randomized clinical trial that they did. So I picked this article just because my background is in psychiatry, so I have seen a lot of people with sleep problems. It's a pretty big problem with quite a few people. And I'm also doing my research project is also related to sleep in truck drivers. So it's just something that I found interesting. So a little bit about the background information. As I kind of mentioned earlier, sleep disorders are really common among the general population. According to the article, they said that about 50 to 70 million US adults are at risk, and approximately 85% of those are undiagnosed or untreated. So people that have sleep problems, but they're not having it addressed or corrected. And this, as you can imagine, has consequences for employee health. So if someone's not sleeping well, then that can be associated with a lot of health problems, such as, for example, obesity, hypertension, type 2 diabetes, cancer, and just generally not feeling well. And then also can result in issues related to productivity, absenteeism, presenteeism, just not as efficient at their work. Um, the World Health Organization estimates that about 3.6 million disability adjusted life years are lost due to sleep issues. So, and then the costs related to sleep issues of insomnia in the US were estimated to be around 150 billion. So, a pretty big problem. So, this study, the design, it was an open label, randomized, parallel group controlled trial. And what they did was they took 1,355 total workers and they divided them into the intervention group and the control group, with 794 in the intervention and 561 in the control. So they purposefully recruited a little bit more into the intervention group to try to account for any type of attrition, like people leaving the study just because they had to do more things than the control, so they could try to have an even amount of to evaluate at the end. And it was a waitlist controlled design, so the intervention group received their intervention up until they were done with follow-up. And at the end of the follow-up, and I think they had up to 9 months, they allowed the control group to get the intervention as well. So they were waitlisted in the meantime. All the participants were recruited from a large healthcare organization. I think with like more than 40,000 employees, if I remember correctly. They originally had planned to do the study differently, but then the COVID-19 pandemic hit, so they switched everything to online. So it was a purely online recruitment process. And what they did was they sent out emails and advertisements, I think also on Facebook and some other social media platforms, targeted to employees that identify themselves as working for this particular healthcare organization. And then they had them go through a screening process to determine if they fit the eligibility criteria or not. And then after they were enrolled, they were randomized by a random number generator that was built into the study webpage. So the inclusion exclusion criteria for enrollment, basically pretty simple. Inclusion criteria, they had to be employed by that particular organization where they were doing the study. It was like I said, a big healthcare organization in the northeast of the US. They had to work during the daytime, and they also had to own and use a smartphone because that was part of the intervention, is that smartphone app. And they had to regularly use smartphone apps so they would be familiar with how to use them. So their criteria was at least once per week. And the exclusion criteria involved anyone working evening, nights, or rotating shifts, and anyone that was pregnant or breastfeeding. So this is just the general overview of how they selected the study design. And as you can see, they started out with 2870 people, and after excluding, they ended up with the 1355, and then they randomized into the two groups, and then how many submitted the surveys over follow-up. And how much they analyzed at the end, it came out kind of evenly as far as the person months that were analyzed. This is table 1. I don't know how well it comes across here, but you can probably see it in the article as well, but that's just generally to show that after randomization, just if you look generally at table 1, the overall demographic characteristics of the two groups, intervention and control, were pretty similar as far as I could tell. Actual numbers, there were more in the intervention, as you remember from the beginning, but overall percentages in each group, they tended to be same on all the major baseline characteristics like age, gender, race, education, and then current health diagnoses. All right, so methods, how do they just design the study? Intervention group, waitlist control group. So the intervention group got their intervention, which included what they called their online shawl program, which was a 20-minute sleep education program. Originally was supposed to be taught in person, like in a class, but they changed that to all be online. And it was a program that talked about like the problems of not having enough sleep, all the research, like a summary of the research of why sleep is important and its relationship to health, safety, and performance, and then gave them some general tips and strategies to improve sleep. And then after this, participants were given what they called the DAYS app, and this is the smartphone app. And what this app would do was give them more personalized sleep training tailored to their specific issues. So I think users inputted whatever sleep issues they are experiencing as well. And I think they also had an option to like link it if they did have any type of smart device like that would track sleep. But ideally, it was try to give them more regular interaction and tips, like similar types of things, sleep education or kind of monitoring how they were doing with sleep and remind them, hey, maybe you should go to bed now, or different types of things like that. And then they were able to, I guess they were followed for up to 9 months. And then at month 10, the waitlist control group were able to receive the online shawl program and the DAYS app as well. So how they came up with, I guess going back here, with the groups of 794 and 561, they did a power calculation, analysis beforehand, and they figured they needed at least 1,000 participants with 500 in each arm in order to achieve sufficient power. So that's why they recruited 1355 in the end. Statistical analysis was done by intention to treat. And they used mixed effects logistic regression models to analyze their outcome measures, which I'm going to talk about in the next slide, but the odds of changing sleep behavior, monthly utilization of healthcare systems, and then incidence of crashes or injuries, and 2 sample t-tests to look at the other outcome measures of sleep quality, sleep duration, mood and energy, and absenteeism or presenteeism. So they had multiple outcome measures. These were the ones that they were looking at with assessing at the baseline, so right when they started the study, and then monthly questionnaires afterwards, and then a final end of study questionnaire. They also asked participants to keep a detailed sleep diary for a few consecutive weeks near the beginning, and then at the end of the study period. Not everyone did that, but the ones that did, they analyzed that as well. And they were looking for overall, like what kind of healthy sleep changes could be observed. And this is, again, all reported via questionnaires from the participants. They were asked about sleep duration, timing on the sleep diary, sleep quality. They assessed that using the Pittsburgh Sleep Quality Index. Um, and then they also looked at absenteeism, performance, and productivity. And they assessed this using the World Health Organization's Health and Performance Questionnaire short form. And additional stuff that they looked at also were mood, alertness, and energy, healthcare utilization, which they assessed, it said just via a validated scale. They didn't name which one. And then also motor vehicle crashes and near crashes. So quite a few outcome measures that they were looking at. So what were the results? I'm just going to go through the tables because they have quite a few charts that show that more easily to see, and then I'll give a summary afterwards. So one of the main things they were looking at were changes in sleep behavior or sleep duration. So as you can see on here, I don't know if this, the it's statistically significant, the intervention group were more likely, I guess, had less fatigue or sleepiness at the end of the study. They reported increased sleep consistency. You can see the p-values and the odd ratios, and 40% like increased sleep duration, and then sleeping in later was like the one that wasn't statistically significant, but the other three were. As far as sleep duration, that also the intervention group showed greater sleep duration than the control group by a little. Let's see, this is not right. Wrong button. On both work nights, so you can see the intervention group had reported a little more sleep than and then the control group, same with on free nights. So if it was not just work nights, they assessed it both on work nights and sleep nights. And they also reported better sleep quality. Results for sleep regularity. It does show that the intervention group was reported more sleep regular, but the p-value, like as you can see there, it was not statistically significant. The other major thing, other than just the actual sleep results, they wanted to see if that affected productivity overall, and they estimated this based on like how much they purported that they were absent, or they asked them questionnaires about presenteeism, and then they assessed that by assigning however much they were making per hour, I think, and try to assess it that way. But as you can see, on absenteeism, it didn't quite meet statistical significance, but on presenteeism, the intervention group reported less overall presenteeism. Results for healthcare utilization. So they looked at it by asking them about, again, like I mentioned, the methods, they're all questionnaires where they asked them about different types of visits, so ambulatory, hospital admissions, primary care, physical therapy, like anything they could think of that would involve healthcare utilization. And the only ones that were statistically significant overall were the mental health visits. So the intervention group reported less, as you can see, like relative risk was 0.72, so they were less likely to have mental health visits, and on overall total visits was less. But the other ones, there really wasn't any statistical association there. All right, so this is basically just a summary of whatever all those graphs I just showed you. So overall, the results from the study were that the intervention group had increased sleep duration on both work nights and free nights. and a lower prevalence of poor sleep quality. You can see 50% compared to 56%. Productivity, so presenteeism was lower in the intervention group. They didn't see any difference in absenteeism. And then you can see the difference in cost. They estimated there about 1,100 to 1,300. So, healthcare utilization, the intervention group had fewer mental health care visits and lower overall healthcare utilization. And energy levels, that was the other one that was statistically significant, is that the intervention group reported higher energy levels, but they didn't notice any differences regarding stress, mood, alertness, or any adverse health and safety outcomes like the crashes. All right, so as far as strengths and limitations of this article, some things that I saw were that I think the overall topic was a good one. It's a common problem. Sleep is a major issue for a lot of people. It was a randomized design. I think the idea of like just studying, trying how we can incorporate technology as part of an intervention, when some people are probably more resistant to try to seek like therapy or other methods of help for sleep issues is useful. And they also looked at like multiple outcomes related that could be related to sleep and not just sleep itself. Limitations, there were quite a few that could affect maybe generalizability and then also just objectivity and biases. So all the data were from one single employer, so it might not be generalizable to all different other types of industries, other types of fields. And then the study participants had to have access to a smartphone and use it regularly. And while I imagine in this day and age, that's probably pretty common, there still probably are some people who don't have access to a smartphone. So it might not be helpful. It's like how generalizable is it to the people who might not use them that often or don't know how. And then another thing was it only looked at day shift workers. So just from other research, people who work shifts, like variable shifts, night shifts, they're more likely to have sleep problems. And then this study only looked at people who worked regular day shifts. Another thing that I thought of was it happened during the COVID-19 pandemic. So that might have affected just the implementation of all the study, I guess, and affected the results in the sense that workers might not have had their usual schedule. A lot of them probably had maybe more time at home, might have been paying attention to sleep more. I know a lot of people that I knew or I kind of remember during COVID-19, everyone was just like, well, we have this time. Let's try to get, like, I want to learn this or I want to get my health better. So that might have affected things. And overall, like, just the whole study was based on subjective questionnaires. So there wasn't any objective data, like actual measurement of sleep hours, et cetera. So that all leads to some possible biases, healthy worker effect, selection biases, recall related to just asking them to self-report how that they slept better, and then the general social desirability. So those that want to feel like look like the app is helping and want to look like they're doing better because of it. So to include the AI, I asked ChatGPT to kind of just give a general conclusion, and this is what it gave me. Combination of the Shaw program and Day's app led to improvements in sleep duration and quality, increased productivity, reduced healthcare utilization among employees, and that it might benefit both employees and employers. I also asked ChatGPT to try to give me a summary based on the ACOM randomized controlled trial guidelines. Basically, it wouldn't really give me a definite answer about what the rating was. It just said that, well, basically said everything was good except for blinding, which is fair. But you notice all the parentheses was assuming this was conducted if clearly defined. So ChatGPT's kind of left it open to, it's like you need to assess and see if this makes sense or not. I also did ask it to give me, I went through and asked for a number out of the because you can get 11 points for the different criteria. And ChatGPT gave me 11 out of 11, even though it said that there was, like, for example, participants weren't blinded, which means you couldn't have gotten a 1 on that. So there's no way it could have been 11 out of 11. So that wasn't quite, this was the ratings that I kind of generally gave it. So probably like a moderately high quality study based on kind of what I saw, but there's probably obviously other issues that don't go into this rating. So that's kind of what I have. These are just a few considerations that first came to mind, but open for questions.
So one thing that came to mind to me was they have this app, and based on the questions they answer as they log in or that they start the app, they would have a customized experience, right?
It's supposed to be, yeah.
What does that mean, right? So
Yeah.
the intervention is no longer controlled,
Right.
right? You no longer know exactly what their experience is going to be because I've chosen this path and this person's chosen this path. So it is an intervention versus control, but the intervention has such variability. I didn't see that. Did they account for
It
that at
doesn't,
all? Or
yeah, that was like the one thing. I don't think they mentioned accounting for it, and they don't even mention it in this paper specifically what the app did. It's kind of vague. I
yeah,
had to dig and they find their, how when they laid out their proposed methods before the trial, that it went into a little more detail, but I'm not really sure how customizable it was because it sounded like it was more the same. I almost felt like when I was reading it, I don't know for sure that they were trying to oversell the app, like what it could do, but I don't know for
it would
sure.
actually make it more scientifically sound if it wasn't customized.
Probably, right?
Everybody saw the same thing.
Yeah,
Then you'd know that it was the thing that they saw that actually might have made the difference.
right.
So related, I didn't find any intervention exposure or participation data. So it's a 20-minute training plus use this app. But they asked the people to rate the app, but they didn't ask how many days out of 30 or 60 or however long the intervention was, did you use the app?
How long yeah.
And what their knowledge test score was on the training. So the intervention exposure is unknown. And then I guess while I've got the mic, related to intervention exposure and intervention effects, it looks like everybody got better control and intervention over time. Right. They didn't report the season of administration or changes related to the pandemic over it. So there's a time there, in addition to any intervention effect, there looks like over the course of time, both groups got better.
Yeah.
And self-monitoring is a widely used clinical psychology intervention tool. And you can, if you're in the control group and you're getting sleep diaries, monthly surveys,
right,
you're engaging in some degree of sleep-related self-monitoring, even if you're not using the app. So I think reporting-wise, more intervention exposure data, season of study would be really helpful because it's probably easy to implement intervention in almost any workplace. There's 20 minutes of training and an app.
yeah.
It's very feasible.
Yeah, that was, I think, the biggest thing that just looking at it before even really reading into the details, my thought was how much is the app versus how much is just them paying attention, because that's usually, and the fact that it was during COVID when people had that opportunity, I think, to pay attention more probably than they would have otherwise, I think would have made probably more of a difference than obvious.
If you're pointing out that the data are subjective, the outcomes, and that there's a natural tendency to say, yes, something is better. I would absolutely agree. And that's been shown in study after study after study. To your prior point, and because that's a huge weakness, right, in this, to your, so ChatGPT says there's not a conflict of interest. Do you mind discussing that and what you think that situation looks like with this paper?
Let me just double check.
Other people may want to comment.
fact that it was funded by I
Yep.
just want to make, by the
Yep.
people who make the app. So yeah.
This is a
I should have put that on there.
industry sponsored trial.
Mhm.
This is a classic industry sponsored trial. Even more so, the two of the authors work for the company, okay? So
That's a big
it's
con.
got major conflicts of
Still
interest
very
that are just
customizable.
screaming.
Right. Hence the feeling why I felt like they were trying to sell the app in the article. So that makes sense.
Exactly. The other thing is I will note, there's something weird at the bottom of table 1. If people look at the self-reported health, those are statistically significantly different by quite a bit, actually. It's probably a p.01 difference, and I don't know why. It begs what happened.
Oh, right. Yeah, that was the one.
22% are missing the data in the intervention side. Only 4% in the control conditions, like something went screwy with this trial.
Yeah, I missed that part.
Yeah, how do you draw a conclusion from that?
So I know I would not give them a 1 on the randomization success.
Yeah, that would lower it. That makes sense. I missed that.
I've got a comment from Micah online. He's asking regarding the 0.72 relative risk value that was reported for the intervention group. Did the study happen to have a relative risk value to compare that to from prior to receiving the intervention?
I don't, let me see. I don't think it did. And that's probably another area that, let me double check. Yeah, I think it's just comparing the two. I don't think they had like a prior, because the healthcare utilization, that seems kind of, I don't know, because it's total visits, but the only difference is mental health care too. And that's another thing that I wonder like how people might report accurately as well. But I don't know. They didn't say, so I'm assuming not.
So this is not just a question for you, but for everybody. What are some of the complications when you have a large conflict of interest, which appears to be the case with this? Why is that a problem?
Tempted to manipulate data or to try to make things look the way you want it to, because you already have a preference for the outcome that you're looking for, because you want to be, obviously in this case the Days app, like they want that to be able to look like it's helpful so they can sell it afterwards.
Yeah, I mean, the science suffers because you're tempted to do something unethical potentially, or even just not necessarily blatantly unethical, but make the findings sound better than they actually are, right? The other thing is, because there's money associated with it, people are getting paid, right? And so if, it's one thing if you're, as a consulting firm, you're being paid to do certain things. But then as a researcher and a consultant, now you're conflating those things because their livelihood is tied to whether or not this sounds good and does well. If it does, they'll get another contract with this company, and so it just becomes a snowballing issue that calls into question not only this study or the studies associated with that, but anything else the
Everything
researcher
else.
may have ever done. Because if they make something look a little bit better here, then maybe they've made their other papers and other things look better. So it calls into question everything they've ever done.
And wouldn't it
That's-
also affect anyone else who cites this article then in the future, and it kind of
Yeah.
affects the direction of research afterwards?
It illustrates the importance of a rigorous conflict of interest management system at universities. Charles Seisler probably has the longest list of potential conflicts of interest of anybody I know. He's the most famous one of the most famous sleep researchers. So like the whole, more than half of these are all Charles Seisler's activities. So is Harvard managing Charles Seisler's potential conflicts of interest?
Apparently not.
Hopefully. No, well,
Well, yeah.
hopefully they are, because he may have to go through the ringer every year because he's so active consulting. And that's what we would hope for here locally too, that, there's a rigorous process to make sure that those potential conflicts are not altering the science.
And one point on the related to this conflict of interest thing is, I think just from reading this and looking at their supplemental materials, if they handed me the data set on a flash drive, I couldn't replicate this. They say mixed effect logistic regression model,
What does
which
that
like,
mean?
do you control for anything?
Right.
Mixed effects, right? And so that also, if those methods are really well documented and are sensible, that can overcome a lot of potential conflicts of interest, I think. But if, it's this opaque, like, well, I chose to use, a random intercept for this and not a random intercept in this other model because I got significance with one or the other. So
I think there's actually some indirect evidence of the degree to which these biases have impacted them. And it's the way they wrote the limitations long paragraph. And if you read, in my opinion, this happens also in non-conflicted studies, but people, I think, who really write well will tell you, look, this is the biggest problem. We have only some objective data, okay? Where is that? Oh, you got to read way the heck into it about 2/3 of the way through. It's kind of buried there in the middle of one of their long sentences. And that's the biggest weakness of the study, and not the one, employer kind of thing. And this is how I think you can kind of, again, it's an indirect inference, but to me, it's pretty powerful, actually, the way you write. It's the
In good journals, if you lead with the most obvious limitation, because the reviewers are gonna see that, they're gonna know that, and if you're not leading with it, then they're like, what's wrong with this? They're gonna then look for other things, right? Not saying that BMJ Open Access isn't a good journal, I'm just saying that they buried the lead when it comes to the
Yeah.
limitations.
Yeah, I kind of noticed that
Yeah.
because I was like, why?
And I mean,
didn't
you
that
know,
order?
this, of course, because so many people are doing their theses and dissertations at this point in time. When you are upfront and honest about stuff, you have credibility, is what Joe, I'm using different words than Joe
Yes.
used.
Yep.
You have credibility. When you bury stuff and hide it and squirrel it away, whatever other people gonna think about everything else that Joe made in different words. So anyway, I encourage you to just be very, simple and direct.
So just follow up on that, how do you see, it's just weird in my mind to have that much problems and be getting into BMJ. Cause in my mind, BMJ is pretty reputable. So is that a common occurrence? Like, or is this something that slipped through the cracks or?
It's not uncommon. There's a lot of journals and there's a lot of reviewers and there's not enough, not enough reviewers to go around, frankly. And so you end up scraping the bottom of the barrel. In a journal that I edit, that I'm an editor on, that I think is a reputable journal, I may go 10, 15 people down the list of reviewers before I find one. And so not to say that the ones that are lower on the list are worse, but it starts to get that way when you go further and further down, right? You're getting away from the experts and closer to people who are more novices in a topic area, and and so you end up either they're novices in the topic area or they're novices as reviewers, and so things get slipped through, right? And reviewers aren't perfect either, right? So BMJ is got some good journals. Not all of their journals are necessarily good, and good, bad things will slip into any journal. It happens.
I don't want to cut off a really good discussion. I want to make sure that Chapman has plenty of time for his.
Chapman doesn't want
anything else on. It's a great keep going. All right, good job, Beth.
Everybody get his own.
start the chain reaction.
That's right.
Did you see my deck?
You know the drill, thing, right?
Or something. Materials and just screenshots of the app. Nothing about the stats at all.
Yeah.
And I know you offered some talk.
Too loud?
I just emailed you to introduce you. Yeah. Great, so you had a good offer.
No, I'm talking about like big chunk.
How are we looking on this thing? Okay. Hey guys, I'm Chapman. Today I'm presenting an article that looks at a PTSD diagnostic tool. Done a lot of these journal clubs, and I just thought it'd be fun to do something a little different, go to the diagnostic realm. Semi-related to what the work I'm hoping to do with my dissertation, but just wanted to look at something a little different. So to give background on PTSD, just to fill everybody in, PTSD is post-traumatic stress disorder. This was added to the American Psychiatric Association Diagnostic and Statistical Manual of Mental Health Disorders, aka DSM, and we're up to the DSM-5 now. In 1980, this was a pretty important movement because it switched the understanding of a traumatic exposure or PTSD, what we know now define PTSD, from an inherent weakness is what it was defined as previously, or traumatic neurosis is what it was called, to a external factor in terms of an exposure to a traumatic event. And more recently, it has been switched from a fear-based anxiety disorder to it kind of in its own realm of trauma and stressor-related disorder within the DSM criteria. But a diagnosis of PTSD heavily relies on an exposure to a traumatic event. And then there's associated symptomology of intrusive thoughts and memories, hyperarousal symptoms, and avoidant behaviors. So the way that we currently diagnose PTSD is the gold standard would be through clinician assessment. So the first step would be answer a short screener that if you test positive, further investigation is required, and then a clinician will perform a structured interview. And a couple examples of that would be these two on the screen. So the most common from what I've seen is the CAPS, the Clinician Administered PTSD Scale. And these can be pretty timely. So if you're working with a provider, their time is expensive, and it can take anywhere from 15 minutes to 2 hours, depending on how comfortable the clinician is with it and how forthcoming individuals are. So this can be kind of a roadblock in assessing PTSD, especially in a research setting. So another way that we can potentially assess PTSD is through a multitude of self-reported questionnaires. They're easy to apply, generally viewed as less accurate. People don't want to use them to diagnose because it's not a clinician diagnosing an individual with a psychiatric disorder. But a few of the examples are here on the screen. You'll commonly see the Post-Traumatic Diagnostic Scale for DSM-5 or the PDS-5 and the PTSD checklist for DSM-5. PCL-5 is probably the most common that you'll see in research. But this study looks at a different version, the primary care PTSD screen for DSM-5 or the PC-PTSD-5. So the study purpose is evaluating, I really can't look down. This study purpose is evaluating the accuracy of the PC-PTSD-5, and it's comparing that to the gold standard of looking at or comparing to a CAPS-5 diagnosis of PTSD. Their purpose behind this was conducted within the VA system, and so their purpose behind it was trying to tell if it can be used clinically at primary care facilities for the VA. And they were another point was they wanted to see what the optimal cut point was for this scale. Just to give a little demonstration as to what that looks like, it is a question on any exposure to potentially traumatic events, and then 5 follow-up questions on whether or not you've had certain symptoms associated with that exposure. So this is a cross-sectional study. They basically recruited individuals consecutively for 16 months at 2 Veterans Affairs primary care clinics. And the way that they would enroll them is they would ask if they were interested in participating in the study. and then give them a lifetime trauma question to do that pre-screener like you would see in the gold standard diagnosis. And if they screen positive, then they would try to enroll them in the study. And to be a participant, you needed to complete all of the data collection that then followed. So that data collection was 2 sessions. And the first session was that in-person visit where they were consented and enrolled. And then once they were enrolled, they filled out a battery of questionnaires. Those included the Patient Health Questionnaire 9, the Audit C, a traumatic brain injury screen, and some other measures. And then within 30 days, they participated in the second session, which was a telephone-based interview. And the first portion was a research assistant administered PCPTSD 5. And then the phone call would be transferred to a clinician that conducted the CAPS 5 interview. And so the way that they ran the analyses was through, they wanted to look at descriptive statistics just to see who was participating, and then potential differences in the those who did not fully complete the data collection and those who did. And then they were doing a cut point measure comparison. So they had 5 potential cut points for those answers on the PC-PTSD 5, and then a binary outcome of the yes/no for the CAPS 5, diagnosed with PTSD, yes or no. And then they were looking at, for those who are in biostats too, we've been looking at this a lot, but the ROC, area under the curve statistic, to see how well that score can predict the outcome of the binary yes/no PTSD diagnosis. And then the way that they wanted to look at the cut point was through the highest score, the highest ROC or AUC score with the specificity set to 0.8. And then secondarily, they wanted to look at if there's any difference in the accuracy based upon gender, and then what would happen with misclassified screens. So how would those get caught from other measures? So moving on to the sample demographics, they had a 31% recruitment rate, which is pretty high from what I feel like I've been seeing post-pandemic. They had a complete data set, so those who were enrolled, 495, those who actually completed all the data collection, 396. There was some differences in the demographics there. Those who completed the data were more likely to be married, less likely to be separated, and I believe less likely to be Latinx. And then age range 21 to 93, mostly male. And then the stat that I thought was pretty interesting was only 22% served during the global war on terror. 80+% came from the previous conflicts. So just jumping right into the results. The overall sample, so when you looked at everybody's results and then separated on gender, you saw a AUC, area under the curve, of 0.927 with a pretty tight confidence interval. And that was for the cut point of 0.3, or sorry, a cut point score of 3. So from my understanding, from the teaching I've gotten, that's a pretty high AUC value. It's very predictive of a diagnosis of PTSD. And then secondarily, there was no significant difference for that value between men and women based upon that chi-square test. So here's your table that would show that, and I highlighted the that cut point that they were liking to use, that they wanted to use, and that specificity score is what they were looking for. Okay, and so moving on, there's the classic limitations of a cross-sectional study. It was non-randomized, and they were collecting data or collecting participants or recruiting participants consecutively. So it was non-randomized cross-sectional data, but I feel like in this kind of a study that's not as entirely important if they're just trying to look at the predictive score, but that is an element of concern. And then there is the aspect of it being a very specific group of people, a very specific sample of veterans who are being assessed at VA primary care clinics. So that can potentially limit the generalizability to the general public. But as they stated in their study, previous iterations of the PC-PTSD had been studied to and shown to have no difference in prediction between veterans and general population. But not this one specifically. It was just for research that they had done previously. And then the response bias, as you can see with the difference in the responders of those who completed versus didn't complete this, the data collection. In terms of strengths, it was a relatively large sample size, no real conflicts of interest. And then there was a gold standard comparison where that assessor was blinded, which is, I think, kind of a hard and expensive thing to do for a study. So it was cool to see that. But what I really wanted to get into is a discussion more on the idea of using screeners in research, maybe not as much like clinically oriented, but for the purpose of a lot of the research that we do here, we look at a lot of survey-based data. And so I just want to have a discussion on that. So keeping it specific to PTSD, would the methods and results from this study make you confident in using this tool for your own study looking at PTSD?
Better and less expensive than having a clinical psychologist be your screen. Or maybe good enough and more and affordable and feasible, I think.
I actually asked the second question to ChatGPT, so I'll show you what ChatGPT had to say, but it was similar to that, where it gave a much more nuanced response than I was expecting.
I mean, the gold standard comparison is very different. Like in the case for sleep, you can compare a self-report screening tool to polysomnography. But in the case of PTSD, it's a screener versus an interview. So it's not like a fully objective secondary assessment, but it's still an abbreviated screener that seems to have good relationship to an in-depth interview by a clinician.
And to my knowledge, there isn't necessarily like a exact prediction of PTSD.
I mean, yeah, the DSM is going to be based on a clinician's assessment of the criteria. So
exactly.
Gold standard in mental health is all based on clinical diagnosis without objective evidence. But that's also similar to musculoskeletal disorders for things like back pain. Where there isn't it's just subjective. How did they get into the study?
How did they get into the study? Primary care seeking veterans.
Right, but how did they get into the study? They didn't, as far as I can tell, they didn't explain this. And this is a key question because when you're talking about the percentage of people who have XYZ and who your comparison group is, as far as I can tell, my guess is that they advertised that it was a PTSD study, and somehow they got some people willing to get in who didn't have PTSD. I don't know, but it's just talks about primary care and was somebody willing to participate in the study? That's what I saw.
In their methodology, they said that they recruited people who were seeking primary care. So anybody who walked through the doors of those two VA clinics, they were recruiting. And then they were incentivized with a $15 gift card for the first session and a $30 gift card if they completed the second session after the collection.
You see what I'm getting at? It's just missing a little bit of information there. The cut point of 3, somebody's got positive. What's the probability they have PTSD? I have a teaching point on that. That's
what's the probability?
Yeah, it's actually in your table.
46%?
That's right. It's coin toss.
Coin
coin toss ads. And I find that folks just pay attention to sensitivity, specificity as positive predictive value. You really have to think about as well because of a coin toss. I always like to put it that way, and all of a sudden people are like, well, wait a minute, I'm not going to go run to the bank on a coin toss. You know, you might put the coin in the bank, but that's a different story.
Yeah, my thing about this is it's fine to have a tool to screen to say, okay, they should proceed to actually get a to meet with a clinician and do the process for an actual diagnosis. But there is some risk there, right? There are false positives, there are false negatives. So you got people that are going to get screened out that probably should have been let in. And so that's all that specificity and, sensitivity and specificity of the instrument. So how much are we okay with when we don't get someone screened into more treatment or more screening, right? Versus not. And I'm not sure what the answer is in this particular case with PTSD.
Yeah, exactly. It's going to depend on factors like what's the outcome if you miss a case.
Yeah.
If it's more severe, you're going to be like, well, wait a minute. We got to maximize sensitivity. And in PTSD,
That's the case when it's a suicidal
Yeah,
situation,
exactly.
then that's a serious miss, right? But if it's they're caught later, they've identified later, and between that time they're miserable, but they're not like dead or hurting other people, then that's a different sensitivity issue.
So I get that from a clinical standpoint, but if you're trying to assess PTSD from a research standpoint, and your methodology might not include the budget for a psychiatrist to diagnose individuals, would in your two perspectives specifically, would that be an acceptable way to assess it?
we'll have Ryan answer that question.
I'm sorry, you have to repeat it. I was
Sorry to.
Just like in a research perspective, like what would you be looking for in terms of either positive predictive value, PPV, or sensitivity specificity?
You would want something that is a reasonable proxy for the gold standard. So, in our studies of truck drivers, we'll administer the Pittsburgh Sleep Quality Index or the PROMIS sleep-related impairment scale. And you just want, the PSQI is indicative, if you get a score of over 5, that you've probably got clinically relevant. You've got sleep problems that would, because the original validation of the PSQI was with clinical patients with sleep problems. So in a research project, if you're not a clinic providing treatment for PTSD, and you would want an indicator of, are you working with a population that has some indication that this might be a concern for them. That's my general take on the research application of using a screener like that.
Interesting.
Same thing applies to like fruit and veggie consumption. Instead of a food frequency questionnaire or a daily photo food diary, the NCI fruit and veggie screener, it's a brief. It's not the gold standard, but it gets you to how many estimated servings of fruits and veggies are people eating a day. So.
Yeah, because it's like for research that we do here, it's okay, well, are we okay with a higher rate of false negatives? And then set that cut point a little higher than what the data would maybe suggest. So like for this example, it'd be they were suggesting the cut point of 3, but you could go to the cut point of 4, and then your PPV goes up to 0.65, so 65%. Is that better, but you have a higher rate of false negatives? Where do you draw the line from like an epi research perspective? That's what I'm curious about for a lot of the research that we do here.
So one element includes what's been done in other studies, because if you start putzing around with what's being done elsewhere, then comparability between studies becomes a problem. You gotta think about that. And if you are gonna change it, you gotta have a decent rationale. packed into there to really say, hey, we're changing this because of this.
Well, I'll wrap it up, but go ahead.
So we already are doing studies with lawyers and I think also with firefighters here where we've used measures such as this for research purposes. But one thing that, for example, IRB requires is that if we see something on those measures that indicates there's an issue, right? Now, in some cases, we can identify, we actually have the individual information and there may be a requirement to report. But in most cases, we don't have individual identifiers, at least for the work that I've been doing. And so then it's a matter of reporting to the organizations potentially. Hey, we strongly recommend you reach out to your people and make sure that these resources are made available, et cetera, right? And that's something that the IRB requires, so that way them experiencing that measure and potentially self-identifying is not creating trauma or problems or bad things for them.
Interesting. Kurt, what is the top end of a ACOM scoring for diagnostic articles?
They're a problem. They are invariably weaker quality-wise than the randomized trials and the treatment side of the fence. As you just saw, people especially would have financial motivation to produce higher quality research that still is conflicted. And the diagnostic stuff much less so. So they typically end up with mid-range. This is way on the better side of what's typically out there on the diagnostic studies. It too has some issues. It's like all research.
Yep.
We keep on doing research.
Yep. Because this one is going to be included in the next guideline, and it got a score of 7.5.
Yeah, that's really good.
So,
yep.
Kind of interesting. Any other questions or comments? Awesome. Thank you for your time.
Final Journal Club of the Year. Thank you all very much for some great discussion this year. Those of you who are coming back next year, we'll see you back in the fall. Those of you who are graduating and moving on, you know where you can get a free lunch on Fridays as long as you RSVP.